This lecture is intended to be a bird's eye view of the infectious disease topics you'll see scattered throughout the course. What we're going to touch on here are the specifics that are going to come up during pediatrics. That is to say, you might have to go review those topics in adult medicine if you're considering them for the shelf. This is not intended to be watched for your USMLE step exams. You should just be watching those medicine videos. But on the off chance you don't have enough time to get through all the pediatrics and to expand on some internal medicine, this is what you got to know for infectious disease in pediatrics for topics covered not in pediatrics. So baby's going to come in, and you're going to have to give consideration to some infections. And really what we're going to be talking about are only the ones or only the elements of each topic that matter for kids. Meningitis is a big one. HIV/AIDS. Osteomyelitis. Septic joints. Skin infections. And this means really the bugs that stay on top of the skin. And pneumonia, which is going to include TB. Okay, so for meningitis, you're worried about brain inflammation. And if you remember from the medicine lectures, you care if the patient is Fales positive. Fales means increased intracranial pressure, and it may not be safe to do a lumbar puncture, so do a CT scan first. But remember, if you're going to do a CT scan, you don't want to wait to give antibiotics because then you'll have a dead patient. So it's blood cultures, antibiotics, CT, LP if Fales positive. If Fales negative, that it is safe to do the LP, antibiotics. In kids, they've got fontanelles. And bulging fontanelles is equivalent of an increased intracranial pressure. Just as is sunken fontanelles is dehydration, bulging fontanelles in a fussy baby are the signs of meningitis. And as you treat meningitis, you're going to choose different antibiotics. In the adult world, you picked vancomycin, ceftriaxone, and at the M3 level, everybody gets steroids. In peds, you're going to do something similar. You're going to give them vanc. And at the M3 level, everybody gets steroids. But ceftriaxone doesn't cover enough now. You need to include ampicillin to cover for listeria, and because ceftriaxone causes hyperbilirubinemia in pediatrics, you want to use another cephalosporin, cefotaxime. And this is going to be for kids who are less than 30 days. Also recognize that Neisseria meningitis is the one that kills people. If you think meningitis and there's a rash, it's Neisseria. You should get vaccinated against that. HIV/AIDS. The things you really got to know are going to be how does baby get HIV and how do you prevent it and diagnose it. So vertical transmission is the thing you care about. That is, mom doesn't know her HIV status or is off meds and is giving birth to baby. The way you reduce the risk of vertical transmission is by giving AZT. Now ideally, mom would be on HAART, her viral load would be 0, her CD4 count would be normal, and baby has very little risk because she's already on retrovirals. But in the case where you can't and you just have to do something at the time of birth, it's AZT to prevent vertical transmission. But then once you have the baby and you don't know if it's HIV positive or not, that is, it is less than 18 months, and you want to know, is it HIV positive? You cannot use an ELISA. An And Eliza gets an antibody, and mom has donated her antibodies to baby, so it may just be an antibody against HIV, but no HIV exists. So instead, for baby, what you need to use is skip the ELISA and go straight to the DNA PCR. And then who gets treated with heart? It's everybody. We presume on the USMLE, especially step 2, that patients can afford their medications, have access, and will take them. So heart for any HIV positive. And then, of course, don't forget about prophylaxis. Just remember the adult age cutoffs. You start prophylaxis a little earlier if you're less than 6 years old, but for the most part, what you want to remember is 200 PCP, trimethoprim sulfa. If you can't use trimethoprim sulfa, use dapsone. If you can't use dapsone, use atovaquone. At 100, it's toxo. People forget about this one because you cover it with trimethoprim sulfa, the same thing you do for PCP. If you can't, use atovaquone. And less than 50, you're worried about MAC, use azithromycin. For osteomyelitis, nothing changes, so only the highlights of this diagnosis. The most common organism is going to be Staph aureus. What will come up in pediatrics is if you see salmonella, you should think sickle cell. It's important to know that Staph aureus is always the most common cause of osteomyelitis. Osteomyelitis usually presents with bone pain. What you have to remember is that if they are toxic, then you will give antibiotics before biopsy. But if they are not toxic, you don't give antibiotics, even if you've made the diagnosis, until you've gotten the biopsy. And the way you work up osteomyelitis, you think there might be osteo because of an overlying cellulitis, or you contract a bone or whatever, you're going to get an x-ray. And if the x-ray is positive for osteo, you can stop and you go straight to biopsy. If it's negative, you're going to do the best radiographic test, which is an MRI. And if that's positive, go to biopsy. Also floating off in the back here is going to be that bone scan, and the bone scan is almost always going to be wrong because the bone scan has false positives when an overlying cellulitis shows inflammation at the site of the bone. The bone scan can't differentiate the skin from the bone. Treatment for osteomyelitis, 4 to 6 weeks. Septic joint, also the same. You've got 2 organisms. Gonorrhea, that's going to be the sexually active teen, hematogenous spread, or staph. Staph is most common, usually caused by direct inoculation, that is, stab wounds. What you're going to do is tap the joint as an arthrocentesis. What you're looking for, greater than 50,000 white blood cells. It's septic, start antibiotics. Skin infections are also very similar, but it is in kids, especially school-age children, where these diseases come up. And so you want to be able to know a little bit about scabies, lice, and pinworm. What they present with, how to diagnose it, and how to treat it. It's all about itching. Scabies have itchy fingers because scabies love to get into the webs of the hands. You make the diagnosis of scabies by doing a scraping, and you can see the little scaby babies. It is the poop and the babies that itch. You're going to use permethrin. You can also use lindane. Lice, going to be an itchy scalp, especially spread by kids who share hats or combs. You're just going to look and you're going to see the nits. These bugs are big. You're going to see the eggs, the nits, and you're going to see the actual bugs themselves. The further away the nit is, the little white thing, the longer they've had it. The treatment is not to cut their hair, but to use permethrin. So you're going to remember something. Permethrin's the one to remember, but also remember there's a backup for both. I only want you to learn permethrin for scabies and lice and lindane for scabies. Pinworm is going to be an itchy butt. So you're certainly not going to mistake this for one of these other diseases. And what happens is baby's got a worm. When the baby sleeps, worm comes out to lay some eggs, scratch the butt, baby puts his hands in his mouth, reintroduces the worms. So the way you find out that they've got worms is by doing a tape test. You literally just leave a piece of tape over baby's butt, and at night the worm comes out and gets trapped. Treat using albendazole. And lastly is pneumonia and TB. Most pneumonias less than 5 years old are probably going to be viral. But otherwise, they're identically the same. Fever, cough, consolidation, ceftriaxone, and azithromycin for community-acquired pneumonias. What I want you to really pay attention to is TB, though. The first thing you should do is ignore the BCG. If someone happens to get BCG vaccine for disseminated tuberculosis, it has literally no impact on pulmonary TB. Those who have gotten the BCG may be frustrated by that statement because they have a huge reaction to the PPD. Too bad. If someone has had a BCG, you ignore it and interpret it the same way. If you are less than 5, you should be getting the PPD, the skin test. If you are older than 5, you should be using the interferon gamma release assay. You treat tuberculosis with either RIPE for full-blown TB or isoniazid, don't forget your B6, for latent. That is to say, latent TB is you have been positive, chest x-ray is negative, or you don't produce any sputum. Positive is, hey, you've got some AFB organisms. Only separate mom from baby if you suspect multi-drug resistant, and mom follows the same diagnostic path. The last thing you have to remember about TB is what's positive for the PPD. 15, 10, and 5. 15 is for people who should never have been assessed in the first place, soccer moms in Wyoming. 10 is the people you should be testing, homeless, prison, healthcare workers. 5 is going to be immunosuppressed and close contacts. Okay, so we've covered a lot of topics in very minimal detail. Pneumonia is in medicine ID. TB, medicine ID. Skin infection is in derm. Septic joints is in rheumatology. Osteomyelitis is in the cellulitis lectures under ID. HIV/AIDS has its own lecture in infectious disease. Meningitis has infectious disease. So you can see that you can go all over this course to start getting the details of this topic. But what I want you to get out of this is the highlights, that the stuff you're going to get tested on and the pitfalls you might fall into having not already learned the medicine topics. That's PEDS ID Review.